I would now speaking to you on bacterial keratitis, and there are no financial or proprietary interests. Now, as Vanati has very nicely depicted, one has to know the risk factors for bacterial keratitis, such as trauma, lid abnormalities, dry eye, VKC, neurotrophic ulcers, use of contact lens, bullous keratopathy, and use of medications such as antibiotics, steroids, and traditional eye medications. Now, this is just to show that traditional eye medications such as honey can cause a corneal ulcer. Then it can occur after surgery like post-LASIK keratitis, and if too much of steroids has been taken with the antibiotics, then this can cause corneal thinning and even perforation. Now, classically, a staphylococcus ulcer looks like this, a punched out lesion with the surrounding cornea which is quite clear. Pneumococcus ulcer would have features like this with corneal edema, and the Pseudomonas ulcers have a yellowish discharge present. The Moraxella ulcers, they tend to be more indolent and oval, whereas the Nocardia ulcers have a wreath-like appearance, and the Mycobacteria ulcers are also very indolent with the surrounding cornea quite clear. Now, one has to grade the ulcer because that determines your treatment modality, mild, moderate, and severe, and the key figure is 2 to 5. So, less than 2, less than 20% superficial, 2 to 5, 20 to 50% mid stroma is moderate, and more than 5, that means more than 50% involvement, and deeper than mid stroma is severe. Now, it is important to get a good microbiology done because clinical examination can predict ulcers only in about 70% of the cases. And after you have done a good scraping and diagnosed the bacteria on the gram stain, sometimes you may have to take up special stains like acid fast, especially recalcitrant cases, which pick up Mycobacterium fortitutum, actinomyces, and Nocardia, and send for culture and sensitivity, which may be positive in 40 to 73% cases. Now, in cases of lamellar cases which occur after post lamellar keratoplasty keratitis or DSEC, you may have to take the material from the interface. In DSEC, you may have to even do an intravitreal biopsy if the infection is occurring only in the lenticule. So the treatment strategy is essentially this. For ulcers which are greater than 3 millimeters in size, involving the visual axis, a combination therapy is given, cefazolin 5% with tobramycin 1.3% for gram-positive and gram-negative organisms. However, if the ulcer is less than 3 millimeters in size, not involving the visual axis, a fluoroquinolone such as a moxifloxacin 0.5% or getafloxacin 0.3% can be given. You give loading dose round the clock for initial 48 hours, and then you assess the response. Now, specific antibiotics may be given if specific organisms have been isolated, that too in recalcitrant cases. So for MRSA, we prefer to give vancomycin. For severe Pseudomonas keratitis, ceftazidime. For Mycobacterium fortitutum, amikacin, and for Nocardia, amikacin or trimethoprim can be given. If there is a perforation or impending perforation, then systemic antibiotics have to be added to the treatment regime. Now, in various studies, it has been shown whenever fluoroquinolones work compared with the combination therapy, that they work in mild to moderate cases, they work in an equivalent manner. That is, there is no difference between the two modes of therapy. This was one study which compared moxiflox with oflox with combination therapy from Australia, which said that there's no difference in healing rate, cure rate, or complications. And this is our study, a randomized control trial in more than 200 patients, which again says that there is no difference in cases of mild to moderate ulcers between fluoroquinolones and the combination therapy. And this is another study which is recently published, which compared getafloxacin with the combination therapy, which did not find any difference between the two treatment strategies. Now, having said that, there could be some amount of resistance. This initial data from RP Center showed that moxifloxacin and getafloxacin isolates were not that resistant, and the susceptibility was there to the order of 96 to 97%. And this data again from LVPI also shows similarly. However, the resistance with the getaflox was seen in only 3 to 7% of the cases, and moxiflox was seen with 3 to 8% of the cases. But with the increased use of this, the organisms are getting resistant to these as well. So these are the newer drugs which we have been using. topical Tazobact eye drops 10% frequently, and topical colistin 0.19% frequently. Again, in cases which have perforation or impending perforation, intravenous colistin is given. But of course, these have to be again used with caution, because if you start using antibacterials, then the bugs gradually get resistant to the ones which are being introduced. The use of topical steroids is controversial. It is added to the antibiotics when the organism is identified. The culture report is in your hand, and when you have already treated the organism with 24 to 72 hours of antibiotics. No topical steroids should be given in cases of ulcers of unknown etiology, or when the ulcers could not be cultured. And there is no role of systemic steroids in cases of microbial keratitis due to bacteria. Now, this is the SCUT trial which took place from Arvind, and said that there is no evidence to support strong effect of steroids, which may be due to the fact that the power of the study was not adequate. And this, in the long-term study, again has shown that bacterial keratitis continues to demonstrate improvement in visual acuity up to 12 months, and further improvements are unlikely. That is to say that whenever you are treating cases of bacterial keratitis, and you have to know when it has healed, it is generally by 1 year, whatever the outcome is there generally occurs. And after 1 year, you can plan a surgical therapy in the form of a lamellar keratoplasty or a penetrating keratoplasty. Now, collagen cross-linking has shown to have some effect in cases of bacterial keratitis, but it is not so effective in cases of fungal keratitis. Some studies have also been done using nanostructured lipid carriers, but these are more or less investigational studies and cannot be extrapolated to clinical situation. So to conclude, newer options in surgical as well as medical management of microbial keratitis are there. Newer drugs are coming up, although they are not commercially available, but we can make them in our pharmacy. And we do need well-designed studies with different drugs which are coming up to establish the role of these new drugs. So these are the two publications we had on corneal perforation in microbial keratitis, which gives the details of the bacterial keratitis as well. And thank you for your attention.